Hello and welcome to another chapter of the ASGBI East Midlands Journal Club. My name is Nina Mary Charles, and I am a junior doctor at Queen's Medical Centre, Nottingham, in the Department of General Surgery. The paper we are discussing today is the Enhanced Recovery Programme versus Conventional Care after Colorectal Surgery in the Geriatric Population, a systematic review and meta-analysis. This paper was published in the Surgical Endoscopy Journal in May 2020, and our three authors hail from the National University of Singapore. Moving on to the introduction. ERAS program, or the Enhanced Recovery After Surgery protocols, adopt a multidisciplinary, multimodal, and evidence-based approach towards improving outcomes following surgery. ERAS programs in general have been found to have really promising results, especially in colorectal surgery. Such programs have led to a reduction in post-operative length of stay, early bowel movement following surgery, and a reduction in surgical comorbidities, without any concomitant increase in readmission rates. Unsurprisingly, this has translated not only to a better clinical outcome, but also potential cost saving for the healthcare systems. Geriatric population, however, is unique due to the intrinsic physiological changes and associated comorbidities. Now, the aims of ERAS actually would lead us to think that the geriatric population would be the ones to benefit the most from it. Because essentially ERAS aims at improving the outcomes which the geriatric patients suffer from. But yet, there's very little guidance for specific management of the geriatric patients within these protocols. The American Society for Colon and Rectal Surgeons and the Early Recovery After Surgery Society have separately released recommendations, but both of these have no consideration given to the safety of recommendations in the elderly. We find that there is a lack of clear evidence suggesting whether such interventions can be safely and effectively applied in the elderly population. The main concern spanning all of these sectors seems to be the fact that there is reduced compliance with the ERAS protocols among the elderly population. For example, things like early ambulation and early oral intake has a lot of person-to-person variation. The methods employed in this study. The study protocol, essentially this is a systematic review and a meta-analysis that is reported based on the PRISMA guidelines. The PRISMA guidelines is the preferred reporting items for systematic review and meta-analysis guidelines. The authors have also applied for a Prospera registration for this study protocol. The search strategy used, essentially what they did was Medline, Embase, and Cochrane Library electronic databases. They filtered through all the manuscripts that were available from inception right up to 19th of September 2019, and manual reference searching of articles was employed. The manuscript language was not a restriction that was imposed. The eligibility criteria applied, essentially all RCTs, prospective and retrospective case control studies with a population of greater than or equal to 65 years of age were filtered through. And we went for elective colorectal procedures. Both benign and malignant diseases were considered, and there was no minimum sample size that was set. Now, if you look at this diagram, this gives a brief idea about the search strategy that was employed by the team. From the databases, roughly 3,392 records were identified. Out of them, a lot of them were duplicates, so they had to be screened. A lot of them were excluded because of the eligibility criteria. And we finally filtered out 6 studies, which were included in qualitative synthesis and also in the quantitative synthesis. The primary outcome measures were post-operative morbidity within the first 30 days, hospital length of stay, and readmission rates. The secondary outcome measures that were analyzed were post-operative mortality within the first 30 days, reoperation, days to flatus, and post-operative ileus. Now, the secondary outcome measures were not really available for all of these studies. They've only been analyzed wherever they were available. The assessment of risk of bias and quality of evidence assessment was done using the Cochrane risk bias tool for the RCTs and the Newcastle-Ottawa scale for the case control trials. The assessment of publication bias, unfortunately, was not really feasible because of the very small number of studies that were available. Data analysis. The primary and secondary outcomes were eventually represented as odds ratio wherever the data was dichotomous, and as mean difference when it was continuous data with a 95% confidence interval and p-value of less than 0.05, sorry. The random effects model based on the Der-Simonian and Laird method was then utilized after assessing the studies for clinical and methodological heterogeneity. Now, this is one of the limitations of the study, the fact that there's so much of heterogeneity, rather differences in the way the ERAS protocols have been employed across the different trusts and different studies. Moving on to the results. Like we mentioned before, finally, we came to 6 studies that were analyzed. 3 of them were randomized control trials and 3 retrospective case control studies. A minimum sample size of 78 and a maximum sample size of 312 between these 6 studies. The total number of patients that were assessed across all of these studies was 1,174 patients. They were all of the age group greater than or equal to 65 years who underwent elective colorectal surgery with or without ERAS. The mean age among the population was found to be 77.85 plus or minus 5, and 56.8% were found to be males. This chart essentially gives an idea of the 6 different studies and the various exclusion criteria employed by each of these studies. And this table gives us an idea of the outcome data. The first one that we were considering was morbidity rate in the patients between the 2 groups, the ERAS and non-ERAS patients. Now, 5 studies have compared the postoperative morbidity rates between ERAS and non-ERAS patients. A meta-analysis of these 5 studies using the random effects model showed that colorectal surgery patients under the ERAS group had lower morbidity rates compared to the non-ERAS group. Now, if I move on to the next slide, that gives us an idea. Excuse me. Figure 2 here gives us a good idea of this. You can see that the odds ratio is 0.38, and this shows us that it's statistically significant. So this forest plot essentially is for postoperative morbidity rate between the ERAS and non-ERAS. And you can see that it favors the ERAS patients. Coming back to the slide with the table, the second outcome that we're looking at is the length of stay in days. Now, five studies essentially again have compared the length of stay in days. All of these 5 studies have demonstrated a significantly longer length of stay in the non-ERAS group as compared to the ERAS group. In addition to this, the Osterman et al. Found total hospital length of stay, which includes primary hospital stay, rehabilitation stay, and 30-day readmission length of stay, to be higher in the non-ERAS group. A meta-analysis of the 5 studies using random effects model, again in the next slide. Here you can see it confirms that it's in favor of the ERAS group. The mean difference is negative 2.49. Coming back to the previous slide. The readmission rate in the Osterman et al. Study did not differ significantly between the ERAS and non-ERAS populations at 8.3% and 7.1%. And this was seen to be the same with the Tejidor et al. Study. There was no statistical significance between the two groups. If we move on to look even at the reoperation rates, there was no statistical significance that was recorded between these two groups in these two studies. Moving on to post-operative mortality, a retrospective case-controlled match study by the Tejidor et al. Reported higher mortality rates following colorectal surgery in the non-ERAS groups as compared to ERAS groups at 11.5% and 1.9% respectively. Time to flatus and post-op ileus were two outcomes that were not very popularly studied on all of the studies, but only some of them have a mention about it. It was found to be not statistically significant within these two studies, the post-op ileus. I apologize for these two very data-heavy slides. Moving on to discussions. So essentially what we have found out from the systematic review is the fact that in ERAS patients, the outcomes are a lot better as compared to the non-ERAS patients. There's fewer morbidities, there's shorter length of stay, and no real significant increase in readmissions in these patients. In addition, there also appears to be a reduction in mortality amongst the elderly patients on an ERAS protocol, although this is just missed statistical significance. The second point of discussion is the fact that previous systematic reviews have not included any recent literature. The two studies in 2018 and the Osterman et al. Study in 2019 had not been included in any of the previous systematic reviews. So that makes this study a bit more current and relevant. And there's a lot of contemporary data and gives a lot of credence to our findings. The main purported mechanism by which ERAS protocol assists with the perioperative recovery is the modulation of inflammatory response as measured by CRP and interleukin-6. These tests can be performed post-operatively to assess what they suggest, and ERAS protocol essentially reduces the perioperative stress, and it's also been found to have positive protective effect on the patient's immune system. The limitations of the study were a few, in fact. The first primary limitation was the fact that a lot of the geriatric population may not really adhere to different aspects of the protocol. And there's no real way to assess this, or there has been no real way to assess it so far. There's significant heterogeneity existing between the ERAS protocols, and this essentially calls for the need for a unified or standardized ERAS protocol that can be adopted by all centers. This encourages us in this direction to reduce this heterogeneity that exists at present. Some of the outcomes are not as well researched, like we spoke about, the time to flatus, the duration of ileus, the outcomes like that, they have not really been as well researched as the other outcomes, like morbidity or reoperation or length of stay. The short-term and long-term functional outcomes of ERAS as well have not really been very clearly studied. So that's not something we can really comment on. And with that, we come to the end of this presentation. A big thank you to our authors for bringing to light such an important topic in such an important population, to be honest, the geriatric population, the ones who are most likely to benefit from the ERAS protocols. And also a very big thank you to ASGBI East Midlands for giving me this platform to bring together this discussion. The topic is now officially open to discussion. Thank you very much.